Assalamu alaikum everybody. So today's class is about clinical cases of nephrology. We'll be solving clinical cases of nephrology from clinical cases FOP as well as STARS book. And there is also some portions from neonatology. Okay, so let us start. Before starting the meeting, I would request if you have left the meeting and once I start sharing the screen, I won't be able to see if you re-enter the meeting again. Okay, so if you again you get stuck, so it's better you just stay in the meeting or just mute yourself. Thank you. And if you're not speaking, please mute yourself. If you have any doubt, you can anytime say it. Should we wait for 2 more minutes then? Okay, let us start. Can you guys see the screen?
Yes.
Yes.
Great. So see, this is our note. This is the chart we are going to follow. So we have nephrology. Where is nephrology? Here we have nephrology. And from the task we have 39, 40, 41. And for FOP, we have case number 4 and 16. So let us move into FOP first. So in total, we'll have 1, 2, 3, 5 cases plus 1 extra case from neonatology. Okay. So let us start from cases of FOP. Just see if somebody is there. Okay. Can you guys see the screen?
Yes.
Okay. This is the clinical cases of FOP. So we are going to do case number 4 and case number 16 because these cases are from nephrology. Okay, let's start. So case number 4. Just move to case number 4. If somebody is out of the meeting and they, ask for getting inside, please let me know. This is case number 4. Okay. So let me clear this everything here. This one is known as case number 4, wet, wet, wet. So the name of the case is wet, wet, wet. So that suggests some kind of like association with nephrology. Okay. So you are seeing patients in the emergency department. Your next patient is 7-year-old boy with 24-hour history of high fever, vomiting, dysuria, and enuresis. Since the age of 3 years, he has had several episodes of high fever that have been unexplained and managed at home. He has past history of proven urinary tract infection. So he had history of urinary tract infection before. 6 months ago, he was managed within primary care. He is developmentally appropriate and toilet trained during the daytime. He does, however, wet the bed. Okay, somebody is asking to let them in. I just finished this. He does, however, wet the bed most nights, passing a large volume of urine that does not wake him up. Okay, so I'll continue the rest of the question after allowing some people. That's why I just posted the meeting a bit earlier, like 15 minutes before, so that everybody can join. Otherwise, there will be a lot of interruption. Okay. So we were here, right? What did we read? We read a 7-year-old boy, and now he is presenting to us with fever, vomiting, dysuria, and enuresis. And he also had previous history of urinary tract infection, and it was proven. It's not simply the features, it was proven history. That means he had done some investigation. Another problem apart from fever, vomiting, dysuria is that enuresis. He wets the bed most of the night, passing large volume of urine that does not wake him up. So it's completely unconscious action. He always have habit of wetting the bed. On examination, his weight is 12 kg, which is on the 0.4 centile, and he is 92 centimeter tall. So what do you see here? The weight of the boy is also very low, as well as height is really low as compared to his age. He's 7-year-old, but look at just 12 kg only. 92 centimeter. He is pale and febrile with temperature of 39 degrees Celsius, blood pressure 121/78. Examination of abdomen is normal except for some left-sided flank tenderness. He has normal male genitalia and bilateral descended testis. Urine dipstick testing is positive for nitrites and leukocyte. There is 3-glucose and protein. So overall, what do we have here? Let us write down the findings. Whenever we have these cases, our main goal is not to solve the questions that is written in the case. We have to get a complete idea of the case. Okay. Is everybody here in the meeting from the group? Okay. So we have this 7-year-old boy. He comes to me with fever, dysuria, vomiting, and also enuresis and previous history of UTI. So what do we think about this fever, dysuria, vomiting? What is our diagnosis now?
Simple UTI.
Yeah, it is a case, we cannot call it simple UTI because he had history of UTI before. So yeah, and he had multiple history of UTI. So we'll call it for now, it is a case of UTI. Okay, when do we call it simple? There are certain criteria. One of the criteria is that it is caused by simple organisms like E. coli. Second one is that the child responds to the treatment within 48 hours. Only then we call it simple UTI. So none of that is proved yet. That's why we're just calling it plain UTI. Okay. So this is the case of UTI. Apart from UTI and previous history of UTI, what is another thing mentioned here?
Ma'am, upper UTI, flank pain.
Okay. What about dysuria? What I think is that this is a case, yes, this is looking more like an upper UTI because usually in upper UTI, they will have fever as well as flank pain. Whereas also, see, dysuria is there. Dysuria is feature of lower UTI. So he actually has features of upper as well as lower UTI, but more on the upper because there is systemic feature, that is fever. Fever is more common, fever as well as flank pain is more common in case of upper UTI. Okay, so we agree this is a case of UTI?
Yes.
Because, and see here they have mentioned it is positive for nitrates, positive for leukocyte, glucose and protein. So yes, they have themselves given us that this is the diagnosis, this is a case of UTI. Now what else? Okay, there are some other people in the meeting. Okay, what else? They have themselves given us the diagnosis. Now, usually for UTI, there is urinary dipstick test. We do 2 tests. One is nitrite, positive nitrite and positive leukocyte esterase. Which one is more specific?
Nitrites.
Nitrites are, is this Dr. Gabby?
No, Shafinas here.
Okay. So this is nitrites, positive for nitrites and positive for leukocyte. Nitrites is more positive and more specific. Okay, so if you have a child who is coming to you with positive nitrite and positive leukocyte, it is a sure case of UTI. Okay, first one. Second one, if you have a child who comes with positive nitrite but leukocyte esterase negative, in that case, what do we consider?
We will relate clinically and will decide on urine culture.
No, this one, because nitrite is more specific, that is why just the presence of, okay, just a minute. Because nitrites is more specific, so just the presence of nitrites gives you an indication that this is UTI. You can immediately start the treatment because nitrite is positive. Okay, but if you have a situation where only leukocyte esterase is positive and nitrite is negative, in that case, what do we think? In that case, we have to look into the clinical sign and symptoms. Otherwise, we cannot start the treatment. Okay. So this child, he has both nitrite positive as well as leukocyte esterase positive. So he's a sure case of UTI. Now that is not the question they're asking. Here they're saying apart from UTI, he also has enuresis. Nocturnal enuresis, as they're saying that most of the time he will wet the bed at night. So this is mostly a case of nocturnal enuresis. Okay. So our child is coming to us with nocturnal enuresis. Now, what are the common causes of nocturnal enuresis? Somebody, please, can you mute yourself? There's a lot of noise. I'll just mute in case you need to speak this. Okay. So, what are the causes of enuresis? Nocturnal enuresis, not enuresis as a whole. Okay. So, first of all, the cause of nocturnal enuresis, commonest cause is UTI. Okay. What are the other causes of enuresis, nocturnal enuresis? One is UTI. Second one is, yes, that is possible. In that case, actually, if it is diabetes, most likely the child will have day and night enuresis because polyuria, it will not be only confined to night. I'm just talking about nocturnal enuresis, only at night. So commonly UTI, constipation, and any kind of emotional stress that triggers the child. For example, parents are divorced recently, or maybe his grandfather died, or recently they shifted to a new school, something like that. Any kind of stress factor. So stress, UTI, constipation, these are commonly the causes of nocturnal enuresis. That means it only occurs at night. But if there is features of day and night enuresis, that is the child has enuresis, involuntary passage of urine during the day as well as night, always you have to think about some pathology. Okay, because say in case of if it is nocturnal, it could be a lot of factors. It could be UTI, it could be constipation, it could be stress. It could be stress, or it could be the child has drank a lot of huge amount of water. It is not always pathological, but that is the organic defect is not there. But if a child is presenting with day and nighttime enuresis, this is a sure sign of overactive bladder. Yes. So it is a sure sign of overactive bladder. So what is overactive bladder? How can we have an overactive bladder? We can have an overactive bladder due to any neurological problems, right? Any kind of injury or tumor in the spine. That's possible. What are the other problems of, what are the other causes of day and night enuresis? Duplex kidney or ectopic ureter. So do you think this day and night enuresis, these are medical causes or surgical causes?
Mostly the surgical ones.
Mostly surgical, but yes, we can do some initial management. We can go for some symptoms, but whenever we see day and nighttime enuresis, it is obviously we have to refer to the specialist, because these are usually caused due to an overactive bladder or due to duplex kidney or due to ectopic ureter. That means your ureter is actually, there will be, especially they'll tell you day and night enuresis or dribbling of urine. Okay, something like that. So now we know the difference between nocturnal enuresis, the causes of nocturnal enuresis and day and night enuresis, right? So this child has come to us with nocturnal enuresis. Now tell me, what could be the cause of this nocturnal enuresis in this child? This 7-year-old who has come to us.
Probably UTI.
Yes, because right now he has UTI. Also, previously he had a history of UTI. So there are two history. There is multiple history of UTI. Please, can you mute yourself if you're not speaking? Please mute yourself if you're not speaking. Okay. So here we have, see, so most likely this child has the stress factor here is UTI. Okay. So this is our diagnosis. Now they are not asking you about this particular case. They're going to ask you about other cases. Okay. So what happens when there is nocturnal enuresis? What is the treatment? First, we are going to learn about the treatment about the case, and then we'll go for solving the question, because there is no use if you solve the questions without understanding. Okay. So we learn what is not. Yes.
Ma'am, can UTI cause day enuresis also?
Commonly, it causes nocturnal enuresis.
Okay.
So common causes, it causes nocturnal enuresis. Now, what happens is that when you have a child with enuresis, what is the important history, especially nocturnal enuresis? What is the important history you need to take? Obviously, you'll ask for history of UTI. You'll ask for history of abdominal pain, because they may not directly tell you about abdominal constipation, but they'll tell you, yeah, occasionally he has abdominal pain, or he is a fussy eater. These are the important words that is frequently used in exam. Fussy eater. So that means he doesn't eat very well. Most likely he'll suffer from constipation. As well as we have to look for some emotional triggers, whether the child has some emotional triggers or not. Okay. Apart from in case of nocturnal enuresis. So you have found, okay, there is an emotional trigger or there is a UTI. So in that case, what are you supposed to do? So if a child has UTI and now he's presenting with nocturnal enuresis, of course, our treatment will be to treat the cause. So what are we going to do? We have to give antibiotics. We have to treat UTI. If the child has constipation and we came to know from the history, he is presenting to us with secondary enuresis. Okay, another thing, what is primary and secondary enuresis? I said you enuresis, nocturnal. What is primary? What is secondary? Primary means this child has never been toilet trained. After his birth itself, like of course, by the age of 2 years or so, child learns to control his bladder, depending on the training. So child was never ever trained, toilet trained. Secondary enuresis is that, yes, initially he was toilet trained, but now he started wetting the bed again. And this developed at least 6 months or more often, several years after the person has learned to control his or her bladder. So initially he was able to control his bladder. Suddenly for more than 6 months, now he's wetting the bed. Then we'll call it secondary enuresis. Okay, these are the common terms. These are not usually asked in exam. Now, okay, so I have this child with nocturnal enuresis, and according to symptoms, I'm going to treat. If he has UTI, I'm going to give antibiotic. If it is abdominal pain, constipation, I'm going to give laxatives. What about if he is a fussy eater or if there is any emotional triggers? What am I supposed to do for that?
Therapy.
Okay, apart from therapy, who's that? Fatiha.
Psychologist.
Motivation, and
Yes.
then star
The first
system.
Exactly. So you'll go for motivating the child, motivation. Of course, you can go for therapy, but as a whole, the first treatment is that you'll go for motivation and star chart. Basically, star chart, instead of motivation, they also write star chart in exam. So basically, you're motivating the child. You tell the child that, okay, if you do not wet the bed today, it's really good. I really appreciate it. So you're going to give him a star chart. Okay. Second thing you can do is that apart from motivation, a lot of things that falls under motivation is that you have to go for some lifestyle modification. That is, if the child had some habit of drinking excessive water before sleeping, you have to stop that. You can encourage the child to drink huge amount of water during the day and evening, but by the night, he has to drink less amount of water. Okay. So first thing is that we are doing some motivation and lifestyle modification. Second thing is that we'll put alarm. At particular time in the night, you have to put an alarm. You have to wake the child up and then you have to take him to the toilet to relieve himself. After that also, if child does not respond, then you go for anticholinergic drugs. And these are mainly given by a specialist. Okay, so we have motivation, alarm, anticholinergic drugs. Now, there is another condition. Suppose you have a child, he's say 10-year-old or 12-year-old or any age, he's coming to you with nocturnal enuresis. But this young child, now he's going for a stayover with his friends, sleepover. And he's very shy about it. He wets the bed. He doesn't want his friends to know. So in this short time, if you put alarm, motivation, actually these methods take a long time. Motivation and alarm, this actually take a long time to act. So in this short time, if you want some action, if you actually want the child to not wet the bed when he's going for sleepover or some camping, then you can give a temporary temporary measurement. That is, you can give desmopressin. Desmopressin is basically the synthetic form of anti-diuretic hormone. So this is absolutely temporary. You cannot give it for long. Okay, so we give a desmopressin. Now, why cannot we give it for long?
Electrolyte imbalances, hyponatremia.
Yes. So yesterday we studied endocrine cases. Tell me why we can't give. Yesterday we did one case about desmopressin. They were trying to distract us. What did we say? So for short time, when we give desmopressin is basically antidiuretic hormone. What is the function of antidiuretic hormone? It will reabsorb huge amount of water, and therefore, what will happen? You are not having polyuria, or it will prevent the child from enuresis. It holds huge amount of water in the body. So what will happen? This is suppose your body, and this is your salt. As compared to your normal water in the body, huge amount of extra water is getting inside your body or is retained in your body. What will happen to the salt concentration? There will be a dilutional effect, and that will lead to dilutional hyponatremia. Did you guys understand this?
Yes.
Like suppose this is your body, and suppose you have a glass of water, and then you're taking half glass of water, and you're told that this half glass of water is suitable. You have to give 1 teaspoon of salt. So this 1 teaspoon of salt is the electrolyte in your body, and it is absolutely perfect for half glass of water. But instead of half glass, I'm giving you full glass of water. Now what will happen to the salt concentration? It will be diluted, right? It will be less salty. That
It
is
will
called
be relatively lower than it
Exactly.
was.
Yes, it will be apparently lower, or it will cause some dilutional hyponatremia. So whenever a child has hyponatremia and you are giving desmopressin for long time, what happens is that the child will develop hyponatremia and can develop seizures due to hyponatremia and other electrolyte disorders. But one of the common ones is seizures. That is why this child comes to you and he is going for camping. Definitely you can go for a night or two, you can give desmopressin, but you cannot continue for long. So for a short time, if we are allowing a child and we want to relieve the child of this enuresis and shame and everything, is really, adolescents, they're very shy about it. So in that case, we can give desmopressin. What is desmopressin? What is the function of desmopressin? Basically, desmopressin itself is a synthetic form of antidiuretic hormone that will reabsorb the water in the body. Okay, so are we clear with this? Why we can't give desmopressin for long?
Yes.
Okay,
Yes.
that means child is coming to me with nocturnal enuresis. In that case, I'm going for motivation. Okay, then I'm going for alarm system. And for short time, I can give desmopressin. And in case still this is not working out, in that case, we can give anticholinergic drug, and this can be given most likely by a specialist. Okay, now what happens is that this is about nocturnal enuresis. What about day and night enuresis? Whenever there is day and night enuresis, the symptoms are present in the day as well as night. You have to exclude certain things. What is the thing you have to exclude? You have to
Tumor,
exclude diabetes
ectopic,
mellitus, diabetes insipidus, any kind of spine tumors, any kind of like duplex kidney or ectopic ureter. Okay. So for diabetes mellitus, what is the test we can do? We can check the RBS, we can do OGTT. Diabetes insipidus, if you want to exclude diabetes insipidus, what we can do?
water deprivation test.
We can do a water deprivation test and we can find out if it is nephrogenic or cranial diabetes insipidus. Spine tumors, this is you have to go for an MRI and mainly you have to refer to neurosurgery. Duplex kidney and ectopic ureter. So how are you going to know? See, for these two, diabetes insipidus and diabetes mellitus, you have some tests to at least identify the cause. But in these three, you do not actually have any test. So what are the findings you'll get? If these three are the cause, in these cases, mostly you will find dribbling of urine. They will say the child is very shy because continuously she is having dribbling of urine day and night. When there is dribbling of urine, immediately you have to think about either any kind of spinal tumor or duplex kidney or ectopic ureter. Okay. You're clear with this? Nocturnal enuresis? Then we have to refer to surgery. Now tell me, in case you are suspecting, this is a 7-year-old boy who has come to us with UTI. So I'm suspecting UTI. At this moment, what is the investigation I should be doing? So we are going to learn here UTI depending on what is the age of the child, whether it is a simple UTI, atypical UTI, or recurrent UTI, we have to do certain investigation. We'll be learning that, okay? So now let us see what are the questions given. So what is the most important next step? What is that you're going to do next? The child has come to you and he came to you with UTI. The features are, it is urinary dipstick positive. Now what to do? Is dipstick positive? It is okay.
Microscopy and culture.
Exactly. We'll do a microscopy and culture because we want to give the antibiotic and we want to make sure that it is actually a typical organ. It is typical or atypical organism. Depending on that, you will be choosing your antibiotic. So next one is that we are going to do urine microscopy and culture. Now let us exclude other causes as well, okay? Because we don't want to be very much, just fixing our mind into one point only. Okay, there was somebody in the meeting. Oh my God, a lot of people. Okay. So what about blood culture? See, our child, first of all, he's a 7-year-old. If this child was less than 3-month-old and he's coming to me with fever, vomiting, UTI, then I could consider a blood culture because in that case, child could have sepsis from UTI. He's a 7-year-old boy. I do not need to consider blood culture. I'm not suspecting sepsis. So this is out. Does he have any features of diabetes mellitus? Yes, he did. Yes.
Yes, enuresis, but it favors UTI more.
Exactly, because the dipstick is positive, so we are not suspecting any case of diabetes mellitus, so blood glucose is out. See, this is the reason they have given blood glucose, because they want you to think about diabetes as well. C-reactive protein. C-reactive protein is very non-specific. It usually increases in all inflammatory condition. We'll get an idea, yes, there is something, inflammatory condition going on in the body, but we'll not get exact diagnosis. So this is out. Full blood count. Do you think is this the next investigation you have done? You have done the urine RME and you have done the nitrates and leukocyte esterase positive. There is no role, because we are suspecting there is no role of full blood count. And moreover, this is a sure case of UTI. Okay. 24-hour blood pressure monitoring. What about his blood pressure? This is nearly normal. This is 121/78. This is nearly normal. And also because we have the diagnosis, this could be due to the stress because of the fever. Maybe it is slightly increased as per his age. So, but this is okay. This is nearly normal. This is not our main thing here. Dimacaptosuccinic acid, DMSA scan. We'll do DMSA.
Not right away.
We'll not do it right away. That will not be our main step in management here, because we want to first give the antibiotics. We have to first treat the child. DMSA usually it is done after like 4 to 6 months, and most commonly after the age of 3 years. We do not do DMSA if it is a case of simple UTI and atypical UTI. Okay, so depending on if it is simple UTI, atypical or recurrent, we can do that, but this is not our next management. They ask for the next step. Okay. Now, okay, this is a different question. Sorry, this is a different question. All right, so from this one, the answer is that which is the next step we are doing. We are going to do urine microscopy and culture.
Onion rings with lots and lots of sauerkraut. Are you ready to order?
Mute yourself. Please mute yourself if you're not speaking. This is really not acceptable. Okay. So in this question, what they are saying is that what is the most important next step? The most important next step is that child is coming to us with UTI. First, we have to do a urine microscopy and culture. We have to give him the antibiotics. Okay, you are done. You have given the antibiotics. Now the next step they are saying, following initiation of treatment. So you have initiated the treatment now, which is the next investigation to be requested. So obviously now treatment you have done, you have got the urine culture microscopy results and you have initiated the treatment. Now what is the next step? So what
Ultrasound.
happens is that whenever a child is diagnosed with UTI and there is certain age criteria, if the age of the child is less than 6 months, 6 months to 3 years, or more than 3 years, according to the age, we have to do certain investigations. Since the age of the child is more than 3 years, in that case, what is the investigation we'll do? In case of a simple UTI, we don't do any investigation. What about a recurrent UTI or atypical UTI? What do you think is this case? Of course, without a culture, it's difficult, but from the history, do we have any clues?
It's a recurrent UTI because he had previous history.
Exactly. He had a previous history of UTI. So most likely this is a case of recurrent UTI. Now, in case of a recurrent UTI, what we have to do? In case of a recurrent UTI, we have to do an ultrasound at 6 weeks, plus we have to do the DMSA at 4 to 6 months. And if it is an atypical UTI, in that case, only we have to do an ultrasound at 6 weeks.
Right away.
Sorry, right away in acute episode. This is in case of a child more than 3 years. So our child is 7-year-old. So for him, if he is atypical UTI, we don't have the results yet, but mostly we are considering him as a case of recurrent UTI. We have to do an ultrasound at the age of 6 weeks, means after 6 weeks, and we have to do a DMSA scan from 4 to 6 months. So what do we have in options? Do we have ultrasound at 6 weeks in this option? We don't have it. What is the next option we have? DMSA at 4 to 6 months. Yes, we have this option.
We have renal ultrasound scan.
We have
D.
renal ultrasound scan, but it has to be in time, has to be given.
Okay, but for DMSA, the time is also not given.
Okay, you are right actually in this way. Renal ultrasound, I think both should be correct. Because if it is a case of recurrent UTI, this both should be correct. DMSA 4 to 6 months and renal ultrasound at 6 weeks. Both are correct. Now they are saying is that what is the next investigation to be requested? So of course, DMSA is going to take 4 to 6 months. Therefore, the next investigation, the earliest investigation will be renal ultrasound. Okay, so both are done usually in case of recurrent UTI. We'll learn it from the guidelines, and also it's a very nice chart is given in this case. What is the next investigation? These two are the investigation which is done usually in recurrent UTI, but which is done next? They are asking for the next investigation. So if we have to choose one option, we'll go for the nearest one, which is done at 6 weeks. For DMSA, you still have 4 to 6 months time. Okay, so our case, 7-year-old boy has come to us with UTI and enuresis. We have decided to treat UTI. So first we are going to do urine microscopy and culture. After that, investigation will start with renal ultrasound at 6 weeks and then DMSA at 4 to 6 months. Are we clear with this? Okay, now see, following the discharge, he is seen in the outpatient clinic. During the clinic, you also see 3 children with enuresis. Now you have some other children with enuresis. Now let us see what are these children coming with, what is the history, and what is the treatment we have to give. So again, they have given us certain management options: alarm system, anticholinergic medication, bladder training, desmopressin medication, laxative. Depending on what is the cause, we have to choose. This is an EMQ. For each of the following scenario, choose the single most appropriate management option. First one, a 5-year-old girl with recurrent UTI and poor growth has daytime dribbling of urine and nocturnal enuresis. That means she has day as well as night symptoms. That means what could be the cause? If she has
ureter.
Exactly. This could be a case of ectopic ureter or a case of duplex kidney. In this case, since this is a matter of surgery, this is actually the work of Department of Surgery, what we'll do is that we'll refer her to a tertiary center or we'll refer her to surgery. See, we have this option: tricyclic medication, refer to surgical tertiary specialist, reduce fluid intake, no intervention. Yes, this is our correct answer. This is the first one. Do we agree? Because she came with UTI and she has day and night symptoms. Okay. Whenever there is day and night symptoms, we think about three things. One is the spinal tumor. Another one is the ectopic ureter. Another one is duplex kidney. All of them has to be treated in the tertiary center or at least by a surgeon. So we have to refer her to a tertiary center. Okay. Next one. A 9-year-old girl who has recently developed straining for her bowel openings with daytime frequency of urination and also episode of nocturnal enuresis during approximately once a month. So what do I have here? I have a 9-year-old girl who is coming to me with straining of the bowel. What is meant by straining of bowel?
Constipation.
Is coming to me with constipation, as well as, see, she's not coming with daytime dribbling or daytime enuresis. She's coming with increased frequency of urination in the daytime and nocturnal enuresis. So what is the diagnosis here? What is the cause of her nocturnal enuresis? Can we call this as a case of day and night enuresis?
Yes, you can.
No, we cannot, because there is increase in the frequency of urination. It's not involuntary. She does not have dribbling. She's having increased frequency. So maybe she's just controlling it. But during night, she does not have any control. So basically during the day, she does not have symptoms. There is only increase in frequency. She's not actually having enuresis or dribbling during the day. So this is clearly a case of nocturnal enuresis due to constipation. So what are we supposed to give in this child?
Laxatives.
Clear case. We are supposed to give a laxative. That's it. Next case, a 7-year-old boy who has been dry at daytime. So they made it very clear he's very dry during daytime. So it is not day and night symptoms. Okay. Since the age of 2 years, but who continues to have nocturnal enuresis every night and would like to be dry for a school camping trip in 2 months. So yes, he only had nocturnal enuresis and he wants to be dry for a school camping. What is that we'll do for short time?
Desmopressin.
We are going to give him desmopressin. So this is our answer. Okay. So whatever I have told, everything, if you go for the explanation of the question, everything is written here very nicely. What are the risk factors for UTI and what is the investigation we have to do for UTI, and then we have some nocturnal enuresis. We're going to give it a read. Okay. So basically, when you read these cases, I keep saying in every class, you just have to read the case. Don't read the question answers. You read the case, first you read the explanation and then go back for solving the answers. Because I have told you the answers by myself, so you did not have to read. If you're doing it by yourself, you have to read it and then go back and solve, because your main idea is not the solving of questions. That's not important. Mainly, they want you to take away the information they have provided in this example. Okay. So what do we have here? See this one, this particular table, it's very, very important. And it is there in the guidelines as well, guidelines of UTI, and this is not changed. So you can definitely refer to it, but mostly if you have any guideline, and these books are from 2014 or 17, so it's better to refer to the guidelines. Okay. But this one is actually very similar and is exactly same as guidelines. So we can look into this. See, so first one, if you have a child with UTI, this is the child's age and characteristic of the urinary tract infection determine further investigation. So what are the investigations you're going to do in a child with UTI? In a child who is less than 6 months of age, if responds well to treatment, or what else I can name this as?
Simple UTI.
Yes, absolutely. If this is the case of simple UTI, if an age of the child is less than 6 months, during acute episode, no need anything. But will need an ultrasound at 6 weeks. Along with that, a DMSA scan at 4 to 6 months. Sorry, nothing is needed, only ultrasound at 6 weeks. That's it. If the child has simple UTI, you do not need to do any investigation beyond 6 months. See, this is the child from 6 months to 3 years, no investigation. This is the child from above 3 years, no investigation. That means if a child has simple UTI and age of the child is less than 6 months, in that case, you only need one investigation. That is, you'll do an ultrasound at 6 weeks. After 6 months, if it is a case of simple UTI, no investigation required at all. Okay. Now, if the child has atypical UTI, by atypical UTI, we mean that if it is caused by atypical organisms, or if the child does not respond to any kind of treatment within 48 hours, in that case, we'll call it atypical UTI. If you see the treatment of atypical UTI, investigation of atypical UTI and recurrent UTI are same in less than 6 months of age. What is that? See, you will do an ultrasound in acute episode. Yes, you will do an ultrasound. As well as you will do a DMSA at 4 to 6 months. So that means in case of atypical UTI and UTI, recurrent UTI, you will do ultrasound at acute episode, that is whenever the child comes to you at diagnosis, plus you will do a DMSA at 4 to 6 months. Okay. Somebody, I think few months ago, somebody knocked me asking that how to study this in an easier way. And I did not feel like I should give a reply. Because yes, you can ask for, if you're not studying something and you keep looking for shortcuts, actually that's not a thing. This is there in the guideline, and trust me, this is one question which is like from UTI guideline. If you have to study two things, it is that this investigation as well as treatment. More than the treatment, this investigation is frequently coming in part 1 as well as part 2 exam. So there's no secret for it that, okay, there's a secret, there's a mnemonic, there's nothing like that. You have to understand, you have to put some effort and actually study it. So this one, see, if the child has atypical UTI or child has recurrent UTI and the age of the child is less than 6 months, then you have to do an ultrasound in acute episode and DMSA at 4 to 6 months. Now, if the age of the child is up to 3 years, in that case, what you will do? In that case, if it is atypical UTI, you will go for an ultrasound in acute episode and DMSA at 4 to 6 months. Can you see in atypical UTI, up to 3 years, the treatment is, investigation is same. See, atypical UTI, 0 to 6 months. Up to 6 months, you're doing ultrasound at acute episode plus DMSA at 4 to 6 months. Same, up to 3 years, you're doing ultrasound in acute episode, DMSA at 4 to 6 months. Can we say that? That means in case of atypical UTI, we have to do up to 3 years of age. We have to do an ultrasound in acute episode, plus we have to do a DMSA at 4 to 6 months, right? Now, what about more than 3 years? More than 3 years, we only have to do an ultrasound during acute episode. That's it. Or I can say that in case of atypical UTI, no matter what is the age of the child, always I will have to do an ultrasound in acute episode. See here. Yes, that means in atypical UTI, no matter what is the age of the child, I have to do an ultrasound in acute episode. Whereas in recurrent UTI, again, it is different. If the age of the child is less than 6 months, it is same as atypical. That is, we'll do an ultrasound at acute episode, DMSA at 4 to 6 months. If the age of the child is up to from 6 months to 3 years, we have to do ultrasound at 6 weeks and DMSA at 4 to 6 months. Next. If it is recurrent UTI, what we are going to do, and if the age of the child is more than 3 years of age, we have to do an ultrasound within 6 months as well as DMSA 4 to 6 months. That's it. So why this is important? The reason is that what happens? They will give you the management. They'll give you some option. The child has come to you and this is a 2-year-old child comes to you with UTI. What is the investigation? Comes to you with simple UTI or comes to you with recurrent UTI? What is the next investigation you're supposed to do? So this is exactly how they'll be framing the questions. This is why you need to be very familiar with this particular table, okay? So study it according to age, because in exam, especially this one, as well as some questions related to anaphylaxis. That is because in anaphylaxis, what did we study? The dose of adrenaline is different in different age, right? That is why in anaphylaxis, what they'll do is that they'll give you the age of the child and they will mention everything that, okay, a 2-year-old child comes to you after ingesting a peanut butter biscuit or something. And now he's coming to you. What is the treatment? And we'll become very happy. Okay, it is adrenaline. But they have given an option 0.5 ml, 0.3 ml, 0.15 ml. What are you supposed to choose? So depending on what is the age of the child, we have to choose the dose. Same goes for UTI. Depending on what is the age of the child, we have to choose the investigation. And this topic is very, very important. This whole case is very, very good case. Okay. So we are clear with this topic. This is like more like we have to study a little bit more. Can we move on to next one?
Yes.
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 Next one is that, see, whatever we have studied from about enuresis, let us see. Bedwetting or nocturnal enuresis is common and distressing condition. The prevalence of bedwetting decreases with age, with wetting less than 2 nights a week having a prevalence of approximately 20% at 4.5 years and 8% at 9.5 years. Okay. More frequent bedwetting is less common and has a prevalence of 8% at 4. Okay, this is not very much important prevalence rate. Now, there are two kinds of enuresis, primary and secondary. Someone with primary enuresis has wet the bed since he or she was a baby. So they never was toilet trained. Secondary enuresis is a condition that develops at least 6 months or often several years after a person has learned to control the bladder. Secondary enuresis accounts for about 1/4 of children with bedwetting. Triggers for secondary enuresis include UTI, diabetes mellitus, constipation, polyuric renal disease, behavioral changes, or emotional events. Constipation commonly associated also. Focused history is important and should determine whether the triggers are present or not. A large volume of urine in the first few hours of night is typical of bedwetting without any underlying renal abnormality. Symptoms suggestive of underlying renal or systemic pathology such as poor growth, uh, recurrent infections, or hematuria. That means if child is coming to us with only nocturnal enuresis in the early part of the night and he is growing well, there is no problem at all. That means it is simple case, there is no pathology. So we'll go for that alarm system, motivation, etc. But if child is coming to us with nocturnal enuresis and there is poor growth, there is recurrent infection or hematuria, in that case, we have to think about some kind of pathology. That is accordingly we have to treat. Now, see here, daytime symptoms may indicate bladder disorder as such as overactive bladder. So if the child has daytime symptoms, it always indicates a bladder disorder. As I said, overactive bladder. See here, is according to the pattern of bedwetting, you have to go. Now, management of bedwetting, what is the alarm signals when they detect the first sign of urine and long-term success, but it can take several months. Okay. Then we have, it also requires a huge amount of commitment. So these are the things you have to do. First one is that if you're suspecting or if you have diagnosed this case that is due to any kind of triggers, emotional triggers, you go for motivation or star chart, then alarm system. In case of camping or if child is staying over, in that case, you'll go for desmopressin, and last one, anticholinergic drugs. Okay. Anticholinergic drug mostly has to be given to a specialist. So this is our case. It is case number 4 from FOP. Are we clear with this? See, in this case, not only we learned about UTI, but we also learned about how to correlate UTI with nocturnal enuresis, right? And what are the investigation we are using in UTI? These two topics are so important, and from nocturnal enuresis, frequently they ask the same questions. So once you understand and you solve some questions, it will be very easy. Okay. And this is how, what are the questions coming from here? They will ask you, child is, as I discussed here, the 2-year-old child comes to you with recurrent UTI. What is the next investigation? A child is coming to you with nocturnal enuresis. They have tried the motivation system, which is the next. or child wants to go for a stay over or for camping, and he wants to be, he does not want to wet the bed. What is the treatment you're going to give? So all this we have to keep in mind. So yesterday we saw a case on endocrine system. Give me a minute. We saw a case on endocrine system. The child comes to you and he was having nocturnal enuresis and he was on desmopressin, right? And suddenly he was on desmopressin. Suddenly he is presenting to you with seizures. And on investigation, you see there is hyponatremia and hyperkalemia. What do you think is the cause? Hello, yesterday people. You guys were all there. We studied that case. We studied that case, isn't it? Yesterday, the child came with, child was given desmopressin, and now he has come to us with this case, like seizures and hyponatremia, hyperkalemia.
Desmopressin is the cause.
Okay, so first of all, if it is only desmopressin, so desmopressin means you're giving antidiuretic hormone, so your water is increasing in the body, what would happen? You will find hyponatremia, hypokalemia. You are finding some contradictory changes here. You're finding hyponatremia, but potassium is increasing. What is the cause? That is definitely not desmopressin. This is the cause of only one hormone, which loves sodium and hates potassium. Which is that hormone?
Aldosterone.
Aldosterone. So whenever you see, they'll try to distract you with certain things that, of course, a child presenting to you who is taking desmopressin is very susceptible to hyponatremia. But at the same time, on investigation, we are going to find hyponatremia only, not hyperkalemia. If at all, we can find hypokalemia. So this was one of the distractions. Whenever you have hyponatremia and opposite in case of kalemia, this is clearly you have to consider aldosterone in your mind. No other hormone has these changes. Okay, opposite hyponatremia, hyperkalemia. Did you guys forget it? We did it just yesterday. Okay, so this was one case. Now let us move to the next case. Next case is, I believe, case number 7. Check. Next case is case number for FOP. Case number 16. Okay. So what do we have here? This is also from nephrology. So in FOP, we have two cases, case number 4 and 16. Let us see here, a swollen face. Alfie is 2-year-old Caucasian boy who presents to the emergency department with a 3-day history of not feeling himself. 2-year-old boy and 3 days history. His mother reports that his face looks swollen and his abdomen is bigger than usual. The family have been unwell recently and had a viral upper respiratory tract infection. So there was a history of infection. Infection 1 week ago. His appetite is reduced but continues to drink fluid well. He is not passing as much as urine but does not have any pain when passing the urine. And he is taking paracetamol as required but no other medication. On examination, he is alert, well, warm, hydrated, and well perfused. Heart rate is 110 and blood pressure is 96/45. He has facial edema and bilateral pitting edema in his ankles extending to the knees. He has a distended, short, non-tender abdomen. The urine dipstick shows protein 4+, blood 1+, no nitrites or leukocyte. He has investigation performed that confirmed nephrotic syndrome and is started on steroids. After weeks of treatment, he begins to respond. So they have given us the entire history that this child is coming to us, his 2-year-old child. He was presenting to us with swollen face and he's not feeling very well and had a history of viral infection. And they ran certain investigations and they reached the diagnosis that this is the case of nephrotic syndrome. And nephrotic syndrome, we know what is the treatment, steroid. He was also found to have heavy proteinuria massive proteinuria. So, okay, he started on steroid. What is that they're trying to exclude here with no nitrites, no leukocyte?
UTI.
Yes, they're trying to exclude basically UTI. Okay, so he started. Now, what is the next investigation? What is the best test to confirm the diagnosis of nephrotic syndrome? So, first test, you have already done it. You see the urinary albumin or urinary protein, and protein was heavy proteinuria. Now, what is the next test you will do?
24 of a urinary protein.
Urinary, you have already checked. Protein is there in the urine. Yes, now we'll go for serum albumin. Because we want to see actually, he can be having proteinuria, but is it sufficient enough to cause nephrotic syndrome? Because when they have proteinuria, what happens? The serum albumin will also reduce, and that can lead to the edema. That is what is leading to the edema. So next one is that we have to check the serum albumin and electrolyte. What about 24-hour urinary protein collection? What do you think about that? Can we do that? We can do that, but the next best one, the best one to confirm, because even if you take urinary 24-hour collection and you saw the urinary protein is very high, but is it high enough to cause some deficiency in your serum or not? That is the question. So that's why after proteinuria, after we have found proteinuria, straight we'll go for serum albumin and electrolytes. Because we want to see if this proteinuria is causing, because anyway you have seen proteinuria. Now what is the function of using 24-hour protein? If they say urinary protein creatinine ratio, we could consider to an extent. That too, urinary protein creatinine ratio, when do we check it? If there was a chronic history or child comes with other features of renal failure, in that case, we can go for protein creatinine ratio. But initially, the initial test is that first we'll go for urinary protein, not 24 hours, just urinary protein. Then we'll go for serum albumin. We want to see, okay, this if massive proteinuria is causing any changes in the serum albumin. Okay, because there will be mainly loss of albumin. And when albumin is lost, the plasma colloidal osmotic pressure will decrease and that will lead to edema. And what are the signs of edema in this child? We have got, he has a swollen face, he has non-pitting edema, as well as he has most likely has ascites, distended abdomen. So this child is actually presenting to us with features of deficient protein, that is protein deficiency, albumin deficiency. So to confirm that, next is we are going to do a serum albumin and electrolyte. What about urine microscopy culture? Why not this? Why are we not selecting this?
Because they are already telling leukocytes, no leukocytes and nitrates.
Exactly. There is leukocyte, asterate, and nitrite is negative. So it is not a case of UTI. That's why we are not considering it. What about renal ultrasound scan? When do we consider renal ultrasound? Is it our initial investigation? Usually, if we are suspecting a case of nephrotic syndrome. Basically, it's not a structural defect. It's not a structural defect, right? It is not a nephrotic syndrome is not due to any kind of structural defect. It's just due to loss of protein. So we are not looking for any kind of renal ultrasound. We are not looking for any obstruction. So that is why we are not selecting this. We'll go for urinary, serum albumin, and electrolytes. Because this is our next investigation. We want to see that he's coming with heavy proteinuria. If at all, this heavy proteinuria has got some deficiency in his body. Okay. Now next, if a renal biopsy were to be performed, what is the most likely histological diagnosis? So they are saying, suppose this patient comes to us with nephrotic syndrome and you have performed a biopsy. What are the changes you're going to find in case of patient with nephrotic syndrome?
Minimum changes is?
Yes, minimal change disease. This is the commonest one. You'll find nephrotic syndrome, especially in children, causes minimal change disease. Okay. What about C3 nephropathy, focal segmental? C3 nephropathy is basically C3 is reduced, I think so, in AGN. I'm not very much sure. Focal segmental glomerulosclerosis. This is usually seen in case of steroid-resistant nephrotic syndrome. Lupus nephritis, there should be some other features of lupus, right? SLE. Membranoproliferative glomerulonephritis. It is mainly associated with AGN. So we don't have any features of AGN. What is one feature of AGN? What do you think here?
Hematuria.
Yes, there should be hematuria, there should be hypertension. This child is coming with blood 1+ in the urine, and the blood pressure is absolutely normal. I think it was, in fact, in the lower range, 96/45. We are not suspecting a case of AGN, we are suspecting a case of nephrotic syndrome, and the commonest change we are going to find is minimal change disease. Okay. Now they have given a list of potential complications of childhood nephrotic syndrome. These are the complications of nephrotic syndrome. Okay. For each of the following clinical situations, select the most likely diagnosis. He develops a sudden onset of macroscopic hematuria with visible blood clots. So all these children have nephrotic syndrome and they have developed some complications. Now tell me, what is that? What is his problem? Sorry? Can you repeat?
Renal vein thrombosis.
Yes, this could be a case of renal vein thrombosis. Now, why? Why are we considering, why do we have thrombosis in case of nephrotic syndrome? Because we know nephrotic syndrome is loss of protein. Now, what's with the thrombosis? What is causing thrombosis? See, protein means all kind of protein, not only one kind. It will be loss of albumin, loss of immunoglobulin, then loss of coagulation protein. All kind of protein will be lost in case of nephrotic syndrome. As a result, what will happen? The child will be very susceptible to infections. The child will be very susceptible to forming thrombus. That is why the child will have increased chances of developing renal vein thrombosis, coming with visible blood clots. This is usually seen in patients with renal vein thrombosis. So we can understand why this child developed renal vein thrombosis, child with nephrotic syndrome.
Yes.
Okay, because of loss of protein. Second one, child has severe headache that does not improve with simple analgesic. Now, from the given options, which one can cause headache? Renal failure, then we have a failure to respond to
Hypertension.
Okay, hypertension can cause. Okay, what else?
Sagittal sinus thrombosis.
Sagittal sinus thrombosis, right? So first of all, what happens? Yes. The reason is that why we are not considering hypertension. Yes, hypertension, definitely it can cause headache, right? But the thing is that in case of nephrotic syndrome, the development of hypertension takes huge amount of time, and it is not usually the first complication. The initial complication is that there will be loss of protein. When there is loss of protein, all kind of protein, immunoglobulin, coagulation factors, transport protein, carrier protein, everything is lost. As a result, the child will have more chances of developing thrombosis. So sagittal sinus, we know the sagittal sinus is in the brain. Sagittal sinus thrombosis can lead to severe headache. And it is not improving even with normal simple analgesia. See, if this was a case of AGN, then hypertension would make more sense. Since nephrotic syndrome does not usually cause hypertension, so we are not considering hypertension. We are considering a case of sagittal sinus thrombosis. Okay. Now, next one, focal segmental glomerulonephritis is seen on the renal biopsy. That means focal segmental, when is it seen?
Failure to respond to steroid treatment.
Exactly. In case of steroid-resistant nephrotic syndrome, so what is the complication? The complication is that patient has developed failure to respond to steroid treatment. If a child is having nephrotic syndrome and we have done renal biopsy and on that we find focal segmental glomerulonephritis, this is a sign that it is not, steroid is not working for the child. It is steroid-resistant nephrotic syndrome. Okay.
Excuse me, I'm not able to view the screen.
Can you guys see the screen? Everybody else?
Yes.
Okay. Can you please? Yeah. So you leave the meeting and join again. I'm waiting for you.
Okay.
Just okay, so this was our case, child presenting with nephrotic syndrome. And after that, what are the common complications of nephrotic syndrome? We studied that it can lead to sagittal sinus thrombosis, infection, renal vein thrombosis. In case of steroid resistant, we are going to find focal segmental glomerulosclerosis. Also, we studied about certain investigations that we are supposed to do. First, proteinuria, that is urine RB. And then after that, we'll go for serum albumin and electrolyte. Okay. This is about nephrotic syndrome. So this was 2 cases about nephrotic syndrome. Everybody is clear? Shall we move on?
Yes.
Yes.
In exam, what they ask about nephrotic syndrome is that I've seen some kind of questions. One is that obviously the options given here, this was very less amount of, questions I have seen with this kind of pattern in the exam. What they commonly I have seen ask them is that they'll tell a child is a patient of nephrotic syndrome. Now he has come to you with vomiting, abdominal pain, and on electrolytes you have seen hyponatremia, hyperkalemia, hypoglycemia. What is the cause? Child with nephrotic syndrome, suddenly child is coming with hyponatremia, hyperkalemia.
Acute adrenal insufficiency.
Yes, why is that?
Because the child was taking steroids and because of infection, maybe he stopped the steroid.
Exactly,
Then,
absolutely correct. I don't know what happened to you people. We discussed yesterday adrenal insufficiency. Child is getting steroid from outside in huge amount. As a result, the steroid in the blood will increase, and that will send negative feedback to the pituitary as well as negative feedback to the hypothalamus, right? And suddenly, if the child skips any dose of steroid, or if the child has an infection, what will happen? His body will not be able to produce the steroid immediately. As a result, he'll suffer from adrenal insufficiency or adrenal failure. This is the kind of question commonly they ask you. Even yesterday we discussed this. Do you guys remember?
Yes.
Okay, it's okay if it skipped your mind, but at least it should be in the memory that, okay, we studied something like that, because otherwise it's going to be difficult. Okay, so we are done with cases of nephrology from FOP. Now we'll do cases of nephrology from clinical cases task. It takes a little bit time if you're discussing and studying like that, but it's very good. It will always stay in your mind, and you can always go back. Otherwise, it's going to take time. Okay. Nephrology, we have case number 39, 40, and 41. So let us move. I think one of the cases is not from nephrology. This is from infection. Okay. Diuresis in a teenager with head injury. So we have case number 39 and I think 40, 41. I'm not sure about 40, 41. Let's see. So we have diuresis in a teenager with head injury. A 14-year-old boy is admitted to the emergency department after a road traffic accident. Even if you're solving in a PDF or you have the physical book, try to mark the most important points so that when you, after reading the entire scenario, when you again look into the questions, you will be able to mark all the important points. So we have child, 14-year-old with road traffic accident. He was cycling without a helmet and was hit by a car traveling at 30 mph. At the scene, he had Glasgow coma score of 5 out of 15. He was intubated at the roadside and taken to hospital. On arrival, the CT scan of the head showed a large left parietal skull fracture, thin extra axial hemorrhage, and an element of swelling over both hemisphere. No other injuries were found on full examination. So there is some huge head injury that has led to hemorrhage. He was transferred to the Pediatric Intensive Care Unit, PICU, and the neurosurgeon inserted an intracranial bolt for pressure monitoring. At 36 hours, his intracranial pressure was at a baseline of 20 centimeter of water, which spikes up to 30 centimeter of water. His urine output begins to rise and his serum sodium is falling. So we have this boy, 14-year-old, who comes to us after a heavy road traffic accident and okay, 14 years with road traffic accident, and he was intubated. He has very low GCS. And after that, okay, his intracranial pressure was initially 20 centimeter. Now it is increasing. Intracranial pressure is increasing 30 centimeter. Normal intracranial pressure is
20.
up to 25. We consider it normal, 25. So it is slightly increasing. As well as they have given us one more finding is that his urine output is increasing. So polyuria. Second thing is that the sodium is decreasing. That means what? Through his urine, we are losing sodium via urine, most likely. Correct? Because if his urine output is increasing and sodium is decreasing, we're thinking, okay, where is the sodium going? So we are considering maybe it could be that. So what is this case? What is the condition? What are the possible causes? What do you think? So yes. Okay, I'm thinking if a child is coming to me with increased urinary output, I'm forgetting about the sodium for now. What are my differential diagnoses? Yesterday we studied polyuria. What do I have in mind? Diabetes insipidus. What else? Diabetes mellitus.
Diabetes mellitus.
Okay, what else?
Increase of fluid load.
Okay, increase IV fluid. That is correct. Okay. What else?
Renal failure.
Psychogenic polydyspepsia.
Psychogenic. Okay, psychogenic is possible, but in this child, it's not possible. But you are right.
Yes.
If urine output is coming, I'll obviously keep psychogenic polydipsia in my mind. Okay. What else? Can I keep a case of salt poisoning? Can I keep in my mind salt poisoning? That means somebody has poisoned him, not him. I'm just telling in general, coming with increased urinary output. So I have poisoned somebody with salt. In that case, what will happen is that the body will try to get rid of the salt. As a result, excessive amount of salt, that is sodium chloride along with water, will be excreted from the body. So in that case also I can find polyuria, right?
Yes.
Okay. Okay. Now, what is happening in this child is that, see, what are the options they're giving? Which of the following conditions are most likely? So they're given us certain options. We have to exclude one by one. Central diabetes insipidus. So what happens in case of central diabetes insipidus?
Low ADH.
Okay, so if we are considering a case of central diabetes insipidus, why this is not a case of central diabetes insipidus? What do you think?
Because in
When
central,
there is hypernatremia in central diabetes insipidus with decreased urine osmolarity.
Exactly. See, in case of central diabetes insipidus, there is no antidiuretic hormone. As a result, what will happen? All your body's water is going out. Right? This is opposite of desmopressin, guys. Please don't confuse. You don't have antidiuretic hormone. In the previous question in UTI, I explained about desmopressin, which is an antidiuretic hormone, so reabsorbs water. Now we do not have antidiuretic hormone. Therefore, what will happen? It will not be reabsorbing the water. An antidiuretic hormone has only action on water. It has nothing to do with sodium, potassium, nothing. So what will happen? Excessive amount of water is going out from the body and there will be no loss of electrolyte. Only water is moving out from your body. What will happen to the salt concentration? So you have, this is your body, you have a glass of water. For half glass of water, 1 tablespoon of salt is enough. But if I'm reducing this half glass of water, or I'm draining all the water out, what will happen to that water of glass of water? Will it become salty or less salty?
More salt.
It will become very salty because I'm draining the water. I'm kind of, concentrating it. So similarly, in this child, if due to lack of antidiuretic hormone, huge amount of water is moving out of the body. So most likely what is he's supposed to get, as the doctor said, absolutely correct. We're supposed to find hypernatremia. But this child has come to us with hyponatremia. So this is definitely not a case of diabetes insipidus. Correct? Agree, everybody?
Yes.
Okay. Now, what are our other differential diagnoses we'll keep in mind? Okay. So what happened is next differential diagnosis is cerebral salt wasting. What is this case, cerebral salt wasting? Basically, cerebral salt wasting is caused due to any kind of trauma. Due to any kind of trauma, what will happen is that the proximal convoluted tubule will not be able to reabsorb sodium. So as a result, what happens? The child will be losing huge amount of sodium. When child loses huge amount of sodium, along with sodium, huge amount of water will be lost from the body. So as a result, we will find hyponatremia. Correct? Due to trauma, and then there will be some changes in the proximal convoluted tubule that will lead to salt wasting. Sodium, it will not be able to reabsorb sodium. As a result, sodium will be lost from the body. That is why it is called cerebral salt wasting. It's not only salt wasting, it is called cerebral because due to injury to the brain. So does our case match with the cerebral salt wasting? What do you think?
Yes.
Yes, there was a history of trauma. And after some time, see, after 36 hours, not initially, after 36 hours, this is very important to mention that it was not initially the child did not present with loss of sodium or increased urine output. He presented after certain time. So after some time, he is presenting to us with these features of hyponatremia and increased urinary output. This could be a case of cerebral salt wasting. Okay, I'm keeping this in mind. I have to exclude other diagnoses as well. What about exogenous excess fluid during resuscitation? Is this possible? Maybe he's, of course, he came with low GCS and, hemorrhage and all that. So maybe he has been resuscitated. And that is why, due to excessive fluid in his body, he is excreting huge amount of urine and sodium is also low due to dilutional effect. Is that possible?
Yes.
That is possible, but what happens is that in those cases, the child would present very early, immediately after resuscitation. Within few hours, the child would present with increased urine output as well as with loss of sodium. But our child is actually presenting to us after 36 hours. This is the reason I told that this 36 hours presentation is very, 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 very important. Okay, so he's not presenting to us early. What about hyponatremic dehydration? So again, hyponatremic dehydration, this could be, even this could be caused due to excessive fluid. Hyponatremia. So these both cases of that results due to excessive fluid, mainly this will present very early in the child within a few hours. That is, after resuscitation, within a few hours, child will present to you with this. If child is presenting to us after 36 hours of resuscitation and everything, that means it is not caused due to excessive fluid. It is also not caused due to dehydration. Okay, this is the difference. This is how we'll make the difference, only because of the timing. That's why the timing is very important. Now, what about syndrome of inappropriate ADH? Is this possible in this child, syndrome of inappropriate ADH? What happens in syndrome of inappropriate ADH? There will be excessive amount of antidiuretic hormone. This condition is exactly opposite to diabetes insipidus. Okay, In syndrome of inappropriate ADH, there will be excessive amount of antidiuretic hormone. As a result, there will be more water reabsorption. And what will happen to the sodium? Sodium will decrease because water reabsorption is more. And therefore, see, think of the glass. You have some salt and you are putting huge amount of water. Shouldn't that be dilutional effect? As a result, sodium concentration will decrease. But will that produce huge amount of urine? Our child is coming with increased urinary output. If you have huge amount of antidiuretic hormone in your body will reabsorb all the water. Therefore, you will have less urinary output. Here he has a huge urinary output. So this is not a case of syndrome of inappropriate ADH. Are we clear with this? Why this is not a case of syndrome of inappropriate ADH?
Yes.
Okay. So therefore, this is most likely a case of cerebral salt wasting due to trauma. Okay. So whatever I have discussed is everything here. Now, what is the next treatment you're going to do for this child? So he's coming to us with this cerebral salt wasting. What is the next thing we have to do? His sodium is low. He's losing water. What do you think we have to do?
Increase the sodium.
We have to, he is losing sodium. He's losing fluid. So we have to give him extra amount of sodium, extra amount of fluid. Because his main pathology is that his proximal convoluted tubule is not working. It is not able to reabsorb the sodium. So what we have to do is that we have to give him increased amount of fluid. Okay. We have to give him increased amount of sodium as well as increased amount of fluid. Let us see which option is that. Decrease fluid, no, this is not the option. Decrease fluid, no. Increase fluid, decrease sodium, no. We need to increase sodium as well as increase the fluid. Increase fluid, increase sodium, yes, this is our correct option. Leave the thing as this is a physiological response. This is not physiological response. This is absolutely pathological due to trauma. Okay. So this is our case. Basically, they wanted to educate us on cerebral salt wasting. And this was a new thing that I learned. But they also made you aware about how you can differentiate it from excess IV fluid, excess antidiuretic hormone or CAD, diabetes insipidus, dehydration, etc. Okay. So see, in this case, very nicely they have written here what happens in case of head injury. What happens in case of head injury and what happens in case of syndrome of inappropriate ADH? Exogenous excessive fluid resuscitation. Let me put this. Okay. This is real risk, especially in teenagers who are treated by adult doctors as if they are adults. Fortunately, hypotonic fluid are now not used to for resuscitation, which makes the potential for fluid shift much less. However, children who are over resuscitated will presuming a normal kidney, develop large diuresis and on occasion may overshoot. This would give a picture of high urine output, hyponatremia, but this would happen early in the illness. So as I said, it will present very early. But our case, it presented after 36 hours, right? So that is why we are excluding this. They said that it will present very early in the illness, if it was due to resuscitation. In the case given is of late development of this problem, it is also most likely that they will become hypernatremic due to excess sodium given in normal saline resuscitation, which overloads the body sodium stores. So if our case of hyponatremia and increased urine output was due to excessive intravenous fluid, it would present very early. Second thing is that due to giving excessive amount of intravenous fluid, NaCl, initially they would present with dilutional effect. Later on, they would present with hypernatremia. But our case is not a case of hyponatremia, nor is it presenting early. That is why this is not a case of excessive intravenous fluid. Similarly, in case of syndrome of inappropriate, how we can differentiate? In case of syndrome of inappropriate, the urinary osmolarity will be very high. Urine output will be very less because they are reabsorbing huge amount of water. Then we have dehydration. Why not dehydration? Again, dehydration can manifest itself as normo, hypo or hypernatremic depending on the relative amount of fluid and sodium which have been lost. However, there will be patients with low amount of urine. So if this was a case of dehydration, one thing is that it would present early. Second thing is that the urinary output would be low, but our child came to us with increased urine output. So this is not dehydration. Central diabetes insipidus. Again, central diabetes insipidus means what we'll find. If this was a case of diabetes insipidus, of course, the urine output would be high as well as the sodium would be high. But why are we not selecting this is a case of diabetes insipidus? Sodium would be high now. Think about this. See, central diabetes insipidus means there is no antidiuretic hormone. So all the water is less from the body. That will lead to increased urinary output. When urine is going, huge amount of water is lost from your body. You will find hypernatremia, not hypo. We got hypo here in our case. Okay. Next one, cerebral salt wasting. Cerebral salt wasting is rare but important complication of head injury. The cause of this is unclear, absolutely unclear, but seems to be due to abnormality in the proximal tubule of the nephron. So exactly, they do not know the case, we do not know, but it seems to cause have an effect on PCT. Where excess sodium is lost, this then draws water with it, leading to hyponatremic dehydration state. One possible cause is that the sympathetic overdrive in head injury causes local hypertension, and the kidney's response is simply a normal hypertension natriuresis response. And the biochemical picture is mixed. So what happens is that due to head injury, they are not very sure. One possibility is that whenever there is head injury or any kind of injury, our sympathetic activity is activated, sympathetic system. So when there is increased sympathetic activity, that will lead to hypertension. And when there is hypertension, what happens to our body? There is excessive amount of, the blood pressure is high. So what kidney does is that when the blood pressure is high, the normal physiological response is that the kidney will try to excrete sodium as well as water. When sodium and water is lost, the blood pressure is going to come back to normal. So basically a diuretic effect. Okay. So this is our case of cerebral wasting, cerebral salt wasting. This is very nicely, like each and every paragraph is excellent. Very, well-formed case. They have explained everything. And here they have given us even some charts, cerebral salt wasting, SIDH, diabetes insipidus, dehydration. In some of the recalls, I have seen that they'll give you exactly their chart and they will ask you to diagnose the case. Suppose they will tell you a child has come to you and he has come with these findings. How can you differentiate? Or what is the diagnosis? So depending on what is the case, you have to understand about hormones. You should have very good idea about hormones. Then we'll be able to make diagnosis. We are clear with this? Okay. So our next question is, I think 40 and 41. Let me just check. Okay, 2, 39, 40. Mode of action of diuretics. This is like easy topic. And this one, I have one video in my YouTube channel. The name of the video is Last Minute Revision. It comes in pink color. And I think I have shared the video in class, right? Do you guys remember during nephrology, I shared the video?
Yes.
So this one is
Yes.
mode of diuretics. We can study from there. Nothing extra. Okay. Diuretics, what are the side effects of diuretics? Common side effects. That's it. Okay. Next one. This is also a nephrology case. A child with kidney and lung problems. Okay. A child, 7-year-old boy, presents to the emergency department with a 3-day history of worsening lethargy, dark urine, and oliguria. His blood pressure is 128/91 and his urine dipstick shows mild proteinuria. On taking further history, it becomes apparent that he had a throat infection 2 weeks ago requiring antibiotic treatment from his GP. So he had a history of infection 2 weeks ago. Now he's presenting to us with lethargy, dark urine. So most likely dark urine means it is a case of hematuria. And also as per his age, the blood pressure is slightly high. In fact, in normal person, it is 120 by 80. This is 128 by 91. So this is slightly high. And also oliguria, that is mild proteinuria. So what are we suspecting? A child, just let us write down. First one is that very important history. There was a history of throat infection. Now he comes to me with oliguria, dark urine, or I can call that as hematuria, and mild proteinuria, and lethargy, and hypertension, or increased blood pressure. I will not classify this as hypertension exactly. This is increase in blood pressure. What do you guys think? What is the diagnosis?
AGN.
Yes, this is most likely a case of post-streptococcal glomerulonephritis. Okay, why? Because they had a very important history 2 weeks ago. Plus there is hematuria and hypertension. All these features are that of AGN. Now, which is the organism that causes AGN? Group A beta hemolytic streptococci. We have to be very careful about group A, group B, etc. Group A beta hemolytic streptococci. Now, what are the conditions? Usually what happens is that if the child has, there are certain post-streptococcal disorders. What are the post-streptococcal disorders? Rheumatic fever, acute glomerulonephritis. These children usually can have rheumatic fever after like around 2 to 3 weeks. AGN also they can have around 2 to 6 weeks. If they had streptococcal illness, that is throat infection, most likely they will have AGN after 2 weeks. If they had skin infection due to streptococcus, then most likely they will have AGN after 6 weeks. That's why they gave the time 2 to 6 weeks. Okay, in case of post-streptococcal glomerulonephritis. Because some people, I've seen this case in one of my family friends, and she did not have much problem. She only came with mild skin infection. And later on, she developed hypertension, hematuria. And then they diagnosed, most likely this is a case of streptococcal infection. Okay, so now we are considering this as a case of acute glomerulonephritis or post-streptococcal glomerulonephritis. Adenovirus, what does it cause, adenovirus? Commonly, we studied that from our recalls. Adenovirus, a lot of things, of course, respiratory tract infection. One of the important thing is that adenovirus causes myocarditis. Okay. Epstein-Barr virus?
Infectious mononucleosis.
Infectious mononucleosis. This is very, 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 very important because infectious mononucleosis is often confused with ALL. What is one thing we can see clinically, which is seen in case of infectious mononucleosis? Palatal petechiae. There will be petechiae on the palate. Okay. And there will be usually thrombocytopenia. And in case of ALL, all systems will be involved, and of course, lymphadenopathy, etc. So this is usually asked in exam, and I've seen that in the EMQs, they will give you an option. Child is about 3-year-old, comes to you with tonsillitis, and also there is lymphadenopathy, and child is very lethargic, etc. And he has developed some rashes, etc., etc. And you saw on blood investigation, you saw platelets are very low. What is the investigation? What is your diagnosis? They have given you option of ALL and infectious mononucleosis. If it is a case of ALL, apart from tonsillitis, the child will have other features. He'll have features of pancytopenia, anemia, thrombocytopenia, increased blast cell feature, frequent respiratory tract infection, frequent infections, limping, testicular swelling, lethargy. This could be the features. But if the child does not have pancytopenic features or systemic features are not very much pronounced, then we can think about infectious mononucleosis. Okay. What about this one, Mycoplasma pneumoniae? Mycoplasma pneumoniae basically causes, it is a case of atypical pneumonia. It usually causes pneumonia in older children and usually infects the lower part of the lung, lower lobe of the lung. Staphylococcus aureus. Staphylococcus aureus commonly, what does it cause? It causes boils, it causes cellulitis, right? Abscess, etc. So we're just going through all the things because these are also commonly asked in our recall, maybe not from nephrology, but from other topics. Next one. So let us move to next one. Given the most likely underlying diagnosis are the following statements, true or false. Now you have to go for ASO titer is likely to be raised. What do you think? In case of streptococcal infection, yes, ASO titer is likely to be raised. C4 is usually low. Is C4 low?
No.
No.
C3
C3.
is usually low in case of AGN. What about in case of IgA nephropathy?
Normal.
All are normal. What about SLE?
Low.
SLE, both C3 and C4 will be low. Okay. So this is wrong. Furosemide will usually lower the blood pressure in this context. So can we use furosemide in this child presenting with acute hypertension? Please mute yourself if you're not speaking. Okay. So can we use diuretics in this child? This is coming with hypertension. Can we use? We can. We can use diuretics. Yeah, because it will lower the blood pressure ultimately. We can use diuretics. It's not only used in one context. It can be used in many things. And moreover, in blood pressure emergency, we have to use diuretics. Okay. Renal biopsy is indicated if proteinuria persists at 4 months. Is it? So first of all, there are certain indications of renal biopsy. What are these indications? There are 3 important indications of renal biopsy. Okay. First one is that proteinuria more than 6 months. Then we have C3 low for about 3 months. 3. Remember like this. Okay. Third one is that if the creatinine is high for more than 1.5 months, or they say 6 weeks. Actually, in this particular paper, they have written in weeks, but I have decided just to, it's very easy in this way. See, 1.5 month, then you double that 3 month, you double this 6 month. 1.5 month of increased creatinine, 3 month of low C3, and 6 month of proteinuria. If these 3 are there, then any one of them are there, then you'll go for biopsy, renal biopsy. These are the indications of renal biopsy. This is not much asked in exam, but I've seen some fastest question old, but nowadays fastest question is like not very relevant for us, for our exam. Okay, these are the indications. Now, renal biopsy is indicated proteinuria persists more than 4 months. No, more than 6 months. So this is wrong. Treatment with penicillin will help to reduce the proteinuria. Can it? Actually,
No.
what happens is that in post-streptococcal illness, yes, you are right, it will not help. But when we give penicillin, it can further prevent any kind of damage. It cannot reverse the damage that has been caused. What happens? How do we get this damage? Why do we have this damage? This is actually post-streptococcal glomerulonephritis. It's a type 3 hypersensitivity. This is also one recall question that AGN. How many letters are there? 3 letters. So remember type 3 hypersensitivity or immune complex mediated hypersensitivity. Rheumatic fever, how many letters are there? 2 letters. So remember type 2 hypersensitivity. This one is frequently asked. Okay. So what happens? First one is that streptococcal infection is entering in our body. After that, whenever an infection enters in our body, our B cell, T cell, everything gets activated and they produce an antibody. This antibody will react with this infection, or we can call this, will react with the antigen. This antigen antibody will react together and form a complex. This is known as antigen antibody complex. This particular antigen antibody complex will be deposited in the glomerulus. When it gets deposited in the glomerulus, now see, somebody is fighting, 2 parties has come to you and they're fighting. Now the police has to come because 2 parties are fighting here. They need to resolve the matter. So what this did, these are the 2 parties that started fighting. So now who is the police? Whenever this immune complex get deposited in the glomerulus, now that will lead to activation of the complement system. And the complement system is the police. They will come and they will cause destruction of this antigen antibody. But since this antigen antibody complex is actually sitting on the glomerulus, that will ultimately lead to destruction of the glomerular membrane. And that is going to lead us to acute glomerulonephritis, inflammation, itis. Okay, so this is a kind of type 3 hypersensitivity, or this is why we have this. Okay, this is usually not asked in exam. It is just for knowledge. It's easy to remember this way. Okay, so we are done with this. We have marked. Now next one, see. Later that day, a 10-year-old. So we have found a child with AGN and we decided we have to do ASO titer and we have to check the blood pressure. We have to use diuretics for the blood pressure. This case is done. Clear with AGN?
Yes.
Okay. Next one, they're asking later, 10-year-old girl presents with similar symptoms of worsening lethargy, reduced urine output and dark urine. She reports feeling unwell over a week and has come to the emergency department due to an episode of hemoptysis. Okay, she is admitted and seen by the renal team who think Goodpasture syndrome is the most likely diagnosis. What happens in Goodpasture syndrome? What are the features? There will be two things, hematuria, hemoptysis. Just remember these two, that is more than enough. So what is the main pathology in case of Goodpasture syndrome? There is actually antibody against the basement membrane of the glomerulus. So we have this glomerulus and there will be some antibody produced against this glomerulus. So that will lead to destruction. And I can't exactly remember the pathology that why it causes hemoptysis, but right now I can't remember. It was something like this particular antibody also, it causes some damage in the lungs. This particular antibody also causes damage in the lungs as well as the glomerular basement membrane due to similarity of structure or something like that was there. So that's why these patients will come to you with hematuria. See, this patient is coming to us with dark urine, hematuria and hemoptysis. So what is the cause? Due to presence of anti-glomerular basement membrane antibody. Easy. What about other things? AGN, low C3. Low C3 is usually seen in case of AGN. This we are not suspecting a case of AGN. Moreover, they have given us a diagnosis of Goodpasture. Presence of anti-RO antibodies. Where do we find this? Anti-RO, anti-LA.
SLE.
SLE. This is also one question that a child comes to you or a young lady comes to you with anti-RO, anti-LA antibody positive. That means she is SLE. What is the most likely congenital heart disease her child is supposed to have? If mother has SLE, the most likely congenital defect or the heart disease will be a complete heart block. Child will present to you with complete heart block. This is one recall question, okay? Next one, presence of double-stranded DNA, dsDNA, where is this seen?
SLE.
This is also seen in case of SLE. Anti-nuclear antibody, this is seen in rheumatoid arthritis. So none of this is rheumatoid arthritis or SLE. We are not suspecting. That's why, what is the main pathology here? Presence of anti-glomerular basement membrane antibody. We'll find this. This is the blood test. Okay. So whatever I have told you is written in this case. Another important thing that we have to keep in mind whenever we are studying AGN is that how to differentiate between AGN and IgA nephropathy. How can we do that clinically? Clinically is that IgA nephropathy, they can also present with hematuria, hypertension very less likely, but mainly hematuria and all the features. And there will be very short history of infection. Say 2 to 3 days ago, the child had a throat infection, or there can be ongoing infection. Whereas in case of AGN, there will be at least more than 2 weeks of history. That more than 2 weeks ago, child had a history of infection. Right? Clinically, we can differentiate with this history that IgA nephropathy, very short history, 2 to 3 days history or ongoing history. These are like recall questions, okay? Okay, somebody just messaged me for letting them in. Okay. So we are done with cases of nephrology. whenever we are studying one case, this is what everything is written here. Glomerular basement membrane, everything. Whenever we are studying any case, just think for some moment, even if you're not studying by yourself, you're listening to a discussion, try to correlate that what are the common recall questions coming in this question, like from this case. This is really important because you can do a lot of discussion, but if you're not having anything saved in your mind, that's not going to help you in exam. So when you're doing this, you have to be okay, fine, from this topic, what is the commonly asked question? So we are done with the topics of nephrology. Now we need to study one topic of nephrology that is basically a part of neonatology. Okay, this is, I think, case number 22. This is also associated with nephrology and a very, very interesting case. And what is the thing we learn about neonatology? Neonatology will be studying in the end, right? Because neonatology is basically the summary of all the chapters. So if you have studied all the systems, neonatology you choose to study in the end, towards the end. Okay, so we have a child with oligohydramnios. How does this relate to our nephrology? We have to keep in mind. We'll study now. We are going to see how it works out. We have Lucy, a 28-year-old woman in her first pregnancy, attends her to 20/40 scan. So at 20 weeks, she's coming for scan with her husband. They are little concerned that Lucy's abdomen is not as big as it should be, but are mostly just keen to find out the baby's gender and are excited to be told that they are expecting a baby boy. Lucy is fit, well, with no medication apart from pregnancy vitamins, so most likely folic acid, vitamin C, iron, etc. Her husband, who is not related to her except by marriage, is also well. What they have excluded here by saying that husband is not related, basically metabolic disorders or autosomal recessive disease. As we know that autosomal recessive disease is a very common. Metabolic disorders are commonly autosomal recessive. They are trying to exclude any kind of familial disorders or autosomal recessive disorder, genetic disorders. Okay, so what do I have here? I have a 28-year-old woman. She is 20 weeks pregnant and she is coming to us with scan, and they're saying that her tummy is not very big, and 20-week scan shows oligohydramnios. So she's coming to us with oligohydramnios. Also, they are very interested to find out the sex of the baby. Okay, and she was not on any kind of medications. Now, what is the cause of this oligohydramnios? Because she does not have any history. She's well and good. Husband is also not a relative, and moreover, she just has been taking medications. Now we are going to study what is this cause of her oligohydramnios, or how this oligohydramnios is related. Okay, let me share the white screen. Okay, can you guys see the screen?
Yes.
Okay, so what happens in a baby is that we know about amniotic fluid. What is this amniotic fluid? So we have this, this is like a sac, like a balloon, and this amniotic fluid has this baby, nice tiny baby. All right. So we have this amniotic fluid, and baby is completely surrounded by a sac that contains amniotic fluid. So what is this function of this amniotic fluid? Basically, first one is that baby is like in a nice bubble sac, and baby can freely move, and also it prevents any kind of shock. Apart from this, we have some other functions. It has antimicrobial function, and it has a lot of nutrients which is necessary for the development of the baby. That means we know that this amniotic fluid is very important for our baby. Now, what is the source of this amniotic fluid? What happens is that initially, that is up to the first few weeks, at least up to the first 20 weeks, what happens? The amniotic fluid is basically taken from the plasma of mother. That is, it is derived from the plasma, squeezing of the plasma, and we get amniotic fluid. Okay. And this particular amniotic fluid is taken from the mother, and that is what we get amniotic fluid up to 20 weeks. After 20 weeks, what happens? After 20 weeks, there are some changes that happens. After 20 weeks, this amniotic fluid source will be from the child. The child will be able to produce some amount from the mother and some amount from himself. How does he produce that? What happens is that whatever amniotic fluid is here, what happens normally, that is before the skin gets keratinized, this particular amniotic fluid freely passes through the baby and goes like this. Okay. Why it is passing through the baby? Because it actually diffuses through the skin of the baby. Okay. Amniotic fluid, it diffuses through the skin of the baby. So it freely passes through the skin of the baby. It provides all the nutrition to the baby, etc. This much are we clear?
Yes.
Initially, baby skin is not keratinized. It is super permeable. That is the reason the amniotic fluid can easily pass through the baby and then come out. Why is it important for this fluid to come out? Because if all the fluid goes inside the baby and it's not coming out, what will happen? The baby will have no amniotic fluid. So it needs to be like in a circulation, basically, just like cerebrospinal fluid, just like the blood in our body, it needs to be circulated. Yes? Please mute yourself. Okay, so this needs to you have to mute yourself, dear. If you're not speaking, just mute yourself. There's a lot of sound. Okay, so this needs to circulate. That is the reason. What will happen is that initially what would happen, all the fluid would just diffuse from the baby, diffuse through the baby. This is good. Understood this much? So this is our baby, and the fluid is just diffusing through the baby. But what happens after by 19 to 20 weeks, there are some changes that occurs. First thing is that the baby's skin becomes keratinized. When it becomes keratinized, now the baby will not be able to become permeable. The skin is not permeable. Second thing is that before this time itself, before 19-20 weeks, what happens? The kidney, the primitive kidney. Now, why am I saying primitive kidney, not only kidney? Because initially this is called primitive kidney, means this kidney is enough to work only in case of fetus. The normal kidney that is seen in case of babies after birth, this usually becomes functional after 34 weeks of pregnancy. Before that, it's not possible for them to function outside the intrauterine life. So that is still known as primitive kidney. They work quite well, but not for the outside world. Okay. So we have this primitive kidney. This primitive kidney becomes functional. So what happened now? This is freely passing. I'm talking before. First, this is happening. The primitive kidney is becoming functional. The fluid is freely flowing here. When it flows here, it sees a nice membrane or nice kidney. It will get through the kidney and nicely flow out. Okay. This was happening before. But now, suddenly, the skin becomes keratinized. When the skin becomes keratinized, now the amniotic fluid cannot pass through this. Okay. Now, what is the problem? Why does it need to pass through the baby? The baby can simply float in the amniotic fluid. No, why do we need this amniotic fluid to pass? Because as I said, it is also a source of nutrition. It is source of nutrition. It is source of antimicrobial. Also, it has to be in a proper circulation. So that is why it needs to pass. Now, what happens is that after 19 to 20 weeks, the skin becomes absolutely keratinized. Now, this amniotic fluid cannot pass through it. How it passes is that now the baby will swallow some amniotic fluid, and this amniotic fluid will go via the gastrointestinal system, and then it will also enter into the renal system, and from the renal system nicely it will be excreted in the form of urine, and again come back to the circulation. Again it will be swallowed by the baby. Again in this way it will go. Because why it is passing through every system is that it has very good function. Amniotic fluid has a huge role in the development of the gut as well as lungs. So it needs to be there in the entire system. So as a result, what is happening is that now how it is maintained after 19 to 20 weeks, the balance is maintained by swallowing as well as by excreting by the kidney. This is how it is nicely maintained. We understood this much?
Yes.
Everybody is clear? This is like a bit new for me. Even when I studied, it was new. Okay. So this is how the circulation is going on. Well and good. But what happens if suddenly the baby stops swallowing? What will happen? If the baby stops swallowing, the amount of fluid in the circulation will increase because that fluid is not actually going anywhere. Same amount of fluid will be accumulated, and it will be increased, right? There will be huge amount of fluid. I'm not taking in. Suppose I'm placed in like a box, and to an extent, like box full of water, like a tiny swimming pool, and I'm supposed to take in some amount of water, but I'm not able to swallow. So will the amount be decreased or increased?
Increase.
Yes, increase, because baby is not able to swallow. So what will happen? The amount of amniotic fluid will remain here and that will increase. And this is known as polyhydramnios. Okay. And that means if the baby has any abnormality or any obstruction in the GIT, which is not causing the baby to take in the food, take in the amniotic fluid, or any kind of neuromuscular defect, which prevents the baby from swallowing. Because, when you have neuromuscular defect, the muscles are not working. So in this case, in neuromuscular defect or in case of GIT obstruction, what will happen? The baby will not be able to swallow. When baby is not able to swallow, what is happening? The amount of amniotic fluid around the baby will increase. Yes? Is this correct?
Yes. Yes.
Okay. As in this case, actually, this is like right hand, like, first hand I've seen this case. One of my friends, she had there was no history towards the last trimester. She had history of polyhydramnios, and they were like, okay, fine, it's okay, polyhydramnios, nothing big deal. They actually totally ignored it, and the baby was born, and he presented within a few days. He presented with intestinal obstruction symptoms, and he was diagnosed as a case of volvulus. So ultimately, the GIT obstruction has led to polyhydramnios. So whenever we have polyhydramnios or oligohydramnios, we have to think about the associated conditions. Okay. So that means we understood if the baby is not swallowing enough, there will be huge amount of fluid in the baby, around the body, and that will lead to polyhydramnios, which is seen in case of GIT obstruction as well as in case of neuromuscular defect. Correct?
Yes.
Okay. Now what happens if the baby, this is a baby nicely, baby is nice and sweet, and baby has kidney, and then this is the bladder, this is the urethra. Now, what is happening if the baby has swallowed enough amount of water? Very well and good. She's swallowing everything. But due to some reasons, there is some obstruction in the kidney. Now what will happen? Now baby is holding all the water. What will happen to the amniotic fluid outside?
Decrease.
It will decrease. That means any kind of renal obstruction causes oligohydramnios, and any kind of GIT obstruction or neuromuscular disease causes polyhydramnios. You understood how it causes oligohydramnios? Because the main function is how it is regulated is that the baby has to swallow some amount of amniotic fluid, and that should nicely pass around the baby and again go back to the circulation. Now, problem is it is entering the baby, but it is not coming out, which has led to scarcity outside the baby. That means scarcity or deficiency of amniotic fluid outside, ultimately leading to oligohydramnios. Correct? So are we clear up to here? Up to here, are we clear why there is only? Yes? Are you clear, or do you want me to explain again?
Yes. Yeah.
Okay. Now what happens is that, what is oligohydramnios? Basically, when the amniotic fluid concentration is less than 300 ml then we call it oligohydramnios. Now, what is my issue if the baby has oligohydramnios? What is our problem? Problem is that when there is, we said that amniotic fluid helps in free movement of the baby. It provides nutrition to the baby. So in the absence of lack of amniotic fluid, the baby will not be able to freely move. Second thing, baby will also lack nutrition. So what will happen is that baby is basically compressed. So what will happen? Baby will develop contractures as well as the lung. It will frequently, the lung will not be able to expand or grow. So what will happen is that the baby will have pulmonary hypoplasia because of compression. So that means what we can see, any kind of renal obstruction, please mute yourself. Renal obstruction. Dr. Ayman, I have muted you a couple of times. Please, Dr. Manjul. Okay, please. Okay, thanks. Renal obstruction leads to oligohydramnios, and this oligohydramnios will cause compression of the baby, and it can lead to contracture. And commonly, the most important feature is that it can lead to hypoplasia of the lung. Are we clear? This is the commonest one. Okay, it can cause a lot of problems, but mainly in the lungs, it will cause hypoplasia of the lungs, as well as it will cause contractures because baby is tightly compressed in a bag. Are we clear with this?
Yes.
Yes.
So whenever this baby is born, the first symptom we are going to find is that the baby will have respiratory distress because baby's lung was so compressed even in after the birth, especially if it is premature, then that's going to be a bigger problem as they mentioned here. But even in a full-term baby, this baby, whenever this baby is born, even in the presence of surfactant, baby's lung will not be able to expand because there is hypoplasia. The lung was never able to grow. That is why, so renal obstruction leads to oligohydramnios and ultimately leads to hypoplasia of the lung. So this baby that is presenting with obstruction, presenting with oligohydramnios in our case, most likely what is he supposed to develop? Due to he has oligohydramnios. So which is one thing he's most likely to develop?
Lung hyperplasia.
He is most likely to develop lung hypoplasia. And what is the cause of that lung hypoplasia?
Due to
Any kind of renal obstruction. So what are the common renal obstructions? We studied that there is hydronephrosis. What is this hydronephrosis? Hydronephrosis means dilatation of the kidney is known as hydronephrosis, pelvic as well as calyces. Why there will be dilatation of the kidney? Due to reflux. This is the bladder, this is the kidney, ureter, then we have urethra. If there is any obstruction here, all the urine will go back and it will accumulate here and cause dilatation. If there is any obstruction here, all the urine from the bladder will go back. It will accumulate in the bladder, pass the ureter, go back, cause dilatation of the kidney. So hydronephrosis can be caused due to any kind of obstruction, right? It can be caused due to pelviureteric obstruction, pelviureteric junction obstruction. It can be caused due to vasicoureteric reflux, basically reflux back. It can be caused due to a posterior urethral valve. These are the kind of complications. These are the kind of obstruction that ultimately leads to oligohydramnios, and from oligohydramnios, we develop lung hypoplasia. Can we understand this? You guys remember we studied this topic in nephrology?
Yes.
Okay, so that means this pelviureteric junction obstruction as well as this vasicoureteric reflux as well as posterior urethral valve. These are very, very important things. Now, which is the most important thing in boy? In a baby boy, the commonest renal obstruction, the commonest one in renal obstruction is posterior urethral valve. This is the commonest one. If a baby is coming to you with renal obstruction and hydronephrosis, and along with that lung hypoplasia, we have to make sure we are excluding this first, because this is like immediately, this is actually a very serious condition as compared to pelviureteric junction obstruction or vasicoureteric reflux. This is more serious. And this is also more common in boys. So what we'll do is that we have to immediately refer to surgery. That is why whenever they are expecting boys or whenever it is told that it is a baby boy, we have to make sure we are excluding this if child is coming with oligohydramnios. Okay. That means, let me just to give you an overview. We studied that amniotic fluid is basically derived from the mother's plasma, but after 20 weeks, it is derived from the baby's plasma itself. And how it is regulated is that it is regulated between swallowing and excretion. So if the baby is not able to swallow, it will increase. If baby is able to swallow, but there is some obstruction, it will decrease. So I can say any kind of GIT disorder or neuromuscular disorder in the baby can lead to polyhydramnios because baby will not be able to swallow. Any kind of renal abnormality or renal obstruction will lead to oligohydramnios. And that oligohydramnios will cause compression of the baby, and this can also lead to lung hypoplasia, which is the commonest one. Okay. Also, oligohydramnios, not that always it is caused due to renal obstruction. It can also be caused due to leakage of amniotic fluid, premature rupture of membrane or leakage of amniotic fluid, right? So this is our case about amniotic fluid. This is very, very interesting case. And this is the best one. It's like, this is one case where they have written in the best way. I've not found this in, I don't know, I have not found in any book. Okay, now see here. Are we clear with this? How the amniotic fluid and everything works?
Yes.
Okay. Now see, which of the following mechanism is most likely result in oligohydramnios in the second half of pregnancy? Why they have mentioned second half of pregnancy? Because before second half, that is before 20 weeks, actually, even if you have renal obstruction or whatever it is, it's not a matter of concern because before that time, the skin is completely permeable. The amniotic fluid is being regulated via the skin by free diffusion. But after 20 weeks, that means after the second half of pregnancy is when skin becomes keratinized, and only when there is an obstruction, and that can lead to oligohydramnios. So they are asking, that's why they have mentioned in the second half of pregnancy. So which of this can lead to oligohydramnios? Antenatal seizure, can it lead to oligohydramnios?
No.
No. Antenatal seizure cannot lead to this. One of the commonest cause of antenatal seizure, what did we study in metabolic disorders? There will be in utero seizures or child becomes hyperactive in utero. Non-ketonic hyperglycinemia. You guys remember this topic? In utero seizures. This does not cause oligohydramnios. Out. Decreased fetal movements? No. Decreased fetal movement, actually, if we can connect this to decreased swallowing, it can cause polyhydramnios, but not oligo. Decreased fetal swallowing, again, decreased fetal swallowing will cause polyhydramnios. Reduced bowel motility, what does it cause? GIT? Obstruction?
Polyhydramnios.
Polyhydramnios. So our answer is renal tract obstruction can lead to oligohydramnios in the second half of pregnancy. What about in the first half? In the first half, even if there is any renal obstruction, the baby is like having free, diffusing freely. This is like free, skin is super permeable. So even if there is renal obstruction, it cannot be actually identified before 20 weeks. Okay. Are we clear with this up to here? Next one.
Yes.
The ultrasonography tells you there is hydronephrosis evident on the scan. What is the most likely diagnosis? So child has hydronephrosis. That means there is some kind of obstruction, right? Amniotic fluid leakage. Can hydronephrosis cause due to amniotic fluid leakage? The fluid is leaking. It cannot cause. Only when there is any obstruction in the renal tract that will lead to hydronephrosis because of backflow. So this is not the answer. Amniotic fluid leakage cannot, in fact, there is deficiency of amniotic fluid that cannot lead to hydronephrosis. Autosomal recessive polycystic kidney disease, that is absolutely a genetic disorder. It is not associated with any kind of other things, and there will be multiple cysts. Okay, and mostly autosomal recessive polycystic kidney disease is seen in case of after, I think, the first or second decade of life. Duodenal obstruction due to annular pancreas, that means the GIT obstruction, can it lead to hydronephrosis? You have your renal system here, your duodenum is somewhere here above. Can this cause hydronephrosis?
No.
No, it cannot
No.
cause. Posterior urethral valves?
Yes.
Yes, if there is any obstruction in the urethra, posterior urethral valve can cause an obstruction. Okay. What about the next one? Potter syndrome. What happens? What is this Potter syndrome? Basically, this Potter syndrome is also caused due to oligohydramnios. Okay. So what happens is that, as I told you, when there is oligohydramnios, what happens? The baby will be compressed. When the baby is compressed, the baby develops frequent features, some features of some certain syndrome. This is known as Potter syndrome. The baby will develop beaked nose and very small baby, contractures in the limbs, as well as lung hypoplasia. It is named after the doctor who has found it. Her name is Emily Potter. So this is also caused due to this Potter syndrome is also caused due to this factor. So can this cause hydronephrosis?
No.
Actually, hydronephrosis due to obstruction, there will be hydronephrosis, and due to hydronephrosis, it can lead to Potter syndrome. Potter syndrome itself is a result of the obstruction. It cannot cause hydronephrosis. Are you understanding? When there is an obstruction, these are the two kidneys. When there is an obstruction here or here, that will lead to hydronephrosis. When it leads to hydronephrosis and no obstruction, when there is obstruction, oligohydramnios. This oligohydramnios can result in Potter syndrome. What they're saying is that why this hydronephrosis is caused. So we know that hydronephrosis leading to oligohydramnios can lead to Potter syndrome. Potters cannot lead to hydronephrosis. It's not reversible. Hydronephrosis is caused due to obstruction. So this is not our answer. Correct answer is a posterior urethral valve. Are we clear why we did not select the other options?
Yes.
Yes.
Okay. Next one is that the baby is born alive at 34 weeks. The most significant medical problem. So baby is having oligohydramnios. The most significant medical problem that we are suspecting him.
Pulmonary hypoplasia.
Pulmonary hypoplasia, because there was a history of oligohydramnios. Very simple. So this, whatever I have told you, if you want this to be stored in your brain for a very long time, then give it a read. Give this one as a read, okay? This is a very good case. Case number 22. Clinical case stuff. It's very, very, very well explained. So this ends all the cases of our nephrology system. Do you guys have any questions? No questions? What about the people in my batch? Any questions? How are you guys studying nephrology? We have the mock, right? Nephrology mock. I think, when do we have nephrology mock? 15th or 16th?
16.
Okay. How you guys studying?
Studying.
Okay. Keep studying. And thank you everybody for joining. And I'll end the class here. Thank you.
Thank you, Akka.